or how do ADCs work? So what is the mechanism of action for antibody-drug conjugates? We have a few, but just to name the most important ones. Number one is the bystander effect, which means that, the antibody-drug conjugate is roaming around in the circulation. It finds the target, it binds to the cancer cell. The cancer cell will swallow it, thinking it's a good thing, because it binds to a very important part of the cancer cell. And then when the antibody drug conjugate releases the chemotherapy inside the cell, the chemotherapy particle can go around in the environment, killing the neighboring cancer cell that might not necessarily express that particular target. And then number two is what we call ADCC, or antibody-dependent cell cytotoxicity. And this goes back to the FC portion that we talked about in the first one or two slides. So when the antibody binds to its target, the FC portion is still available for immune cells to come and bind and also kill the cancer cells via immune activation. Number three is the antibody-antigen binding. So if you guys remember, when we described the antigen, we said that it has to be very important for the cancer cell machinery. So when the antigen or the ADC binds to the antigen, it gets internalized or swallowed, thinking it's a good thing. So that by itself disrupts the cancer machinery and lead to kill cell, or basically the dying of the cancer cell. And then number four is receptor blockade. Very similar concept. These receptors are very important. So when you block them, they can't interact with each other. So that affects the signal transduction downstream from that receptor, and then also leads to apoptosis, or basically death of the cancer cell. So of course, as anything else, there is always resistance, or the cancer always can develop resistance to these ADCs. So what are these mechanisms of resistance? Number one is target antigen related. So the cancer will learn that we're trying to target that antigen, so it just stops expressing that target. So down regulation of the expression of that particular protein or target. Number two, it can do what we call decreased internalization. So we explained that when the ADC binds to the target, the cancer cell will internalize it. So it will just stop doing that. So stops producing the enzymes that internalize the proteins, and will increase the production of the enzymes that causes efflux, or basically kicks these proteins out. Number three is lysosomal dysfunction. So when the cancer cell swallows that ADC, in order to degrade it, it creates something called lysosome, and it's basically an acidic bubble that breaks down the proteins. So that bubble, the lysosome, just becomes less acidic. When it swallows that ADC, it just stays there and it cannot release that chemotherapy. Number four is payload related, which means that the cancer cell can develop resistance to the chemotherapy that we have attached to that ADC. And lastly, some other less common mechanism of resistance that I think we talked about very generally so far. So what are examples of ADCs in lung cancer? We have Dato-DXd, which is approved in EGFR. We have Teliso-V, approved in patients with non-small cell lung cancer that express MET in higher level. We have, I don't have it here, but there's also T-DXd that is approved agnostically in all cancers, but also there is an approval in HER2 positive non-small cell lung cancer. And there are some other, promising ADCs that are coming to the market, such as IDXd in small cell particularly. So how can we improve? What are the future perspectives? How can we do better in ADCs? Number one, we can try to change the structure of the ADC, making it bispecific, trispecific, a lot of things. We can work on the payloads, not only chemotherapies. We can attach maybe some immunotherapies to it. We can, the dual drug, or maybe the novel linker or conjugation. So play on that, DAR, play on the linker, play on the number of chemotherapies that we're attaching to the ADC. There is a lot of things that we can do. We can also develop new targets, right? We always come up with new targets as we understand cancer or lung cancer more and more. We can develop biomarkers for the ADCs that we have right now. Try to understand, which patient population they work better for. And lastly, novel combinations. Combine them with immunotherapy, with targeted therapy, with other types of treatments that are coming to the picture.